Thank you, Dr. Dinesh. And I'm going to talk about how to interpret this OptoView OCT. And we all have lots of OCTs, but just remember one thing, we can't compare one with the other. Each one is different. And since, excuse me, it's not working. Yeah. All right. So, we have evolved. The OCT is also evolved. 1996, first commercial OCT, speed scan of only 100 A scans per second, depth resolution of only 16 microns. And we have now come up to 2020, Solix, it scans 1,20,000 A scans per second. Very important. First, when you're buying your machine, look at the normative data. In the RTView, this has got a huge database. 10 clinical states worldwide were checked out for this kind of clinical data. 555 eyes. To us, it seems, oh my God, only 555 out of all the millions in the world? Remember, this is one amongst the biggest normative data amongst all the OCT machines that we have. They have gone about an age range of 18 to 82. This figure must be remembered. If you've got a child of, let's say, 15, you've got no normative data. It's very important for us to remember that. Ethnicities, they've covered a wide number of ethnicities: Asian, Hispanic, Caucasian, African American. Now, whether us Indians are in this Asian group, we don't know. So in the Cirrus, there are only 5 or 6 Indians. Remember, our eyes are different from the others. The RTView scans the optic nerve head, the ganglion cell complex, and also the enhanced macular map. Now, before we get on our toes and say, get, set, go, we have to check what is the signal strength, what are the motion artifacts, have we acquired a correct image, and do we have access to raw data whenever we require it. So the first part of any scan is what? What is the information about the patient? What is his name? His age. Age is extremely important because we are comparing everything to the normative data. And therefore, the age, sex. Sex is also very important because remember, males and females, the optic disc size is also different in different ethnicities. You have to check what examination date. Why? Because you want to know progression. Glaucoma is a progressive disease. Time, okay. Date of birth, I've said. Patient's registration number, all of it, because A person, B person, they're different. Now we come down to very important. Please have a look at what is the quality of the scan. As per the manufacturer, in the RTView, SSI of over 40 is considered to be correct. Anything above 40 is correct. Cirrus, it's different. Above 7/10, it is considered to be good. Don't take a scan or don't accept a scan which is not of the SSI qualifications as per the manufacturer. Now remember, if you look at the figure here, look at this, SSI 41, SSI 25. Now this is of the ganglion cell complex. This is of the optic nerve head. Why is there a difference in the two? Because when you're looking at the ganglion cell complex, which is nothing but the macula, you're looking straight ahead. When you are looking at the optic nerve, you're looking more nasally. As a result, the iris casts a shadow and you might not get good signal strength. Very important to measure this because if it is unreliable or subpar, your inaccurate data confounds interpretation of your OCT result. Suppose you've got a faint image, your software is unable to accurately determine the boundaries. It is the boundaries which we are concerned with of the layers that it is being able to measure. Remember, we are segmenting the entire retina, segmenting the parts of the retina which is by the side of the optic nerve head. Therefore, you have to have correct signal strength. Now, this will lead to what? Improper clinical decision making. Therefore, a reduced scan quality might show a reduced thickness. And you think, oh my God, this guy perhaps has glaucoma. He doesn't. You've not seen the signal strength. How do we improve it? Make the patient blink before taking the scan. That means if your cornea is dry, your scan is not going to be that good. If you find that the patient is not, you're not getting good scans, put one drop of, let's say, some kind of lubricant. Accurate acquisition of image without the cut-off images. I will show you pictures, how that matters. With good centration, therefore, when you are taking the optic nerve head, doing an OCT, see to it that your optic nerve head, the scan is right in the center. And subsequently, that machine of yours should be able to center it over there all the time, right? So number 1, number 2, number 3, all of them, the centration should be accurate. Motion artifact, remember your eyes keep on having microsaccades. How much? Approximately 5 microsaccades per second. That's normal. So unless there's an image tracking, motion artifact is very likely to occur with even the most cooperative patient. So try to reduce it. Now, when we are taking the scans, what are the scans being taken? They are therefore, you have the circular scans like this. These circular scans approximately 3.7 millimeter, 1.3 to 4.9 millimeter. Why is this important? Because remember, you have PPAs. And suppose you've got large PPAs, it's measuring what? It's measuring the PPA and not measuring the retinal nerve fibers layer. So that's very important. Then you've got the radial scans. These are the radial scans. These radial scans are how many? 12 of them. And this is for the optic nerve head margin, shape, and they're approximately 3.7 millimeter in length. Now, once you've got the scan, and now you've got, this is the image that you have got. So what is it? This center light gray is what? Optic cup. What is this darker gray area? This is nothing but the optic, the neuroretinal rim, which we are so concerned about. And then after that, we should get what? An hourglass pattern. Look at this hourglass pattern. Now, we don't have that. We don't have any of the reds over here, the yellows over here. Just looking at that only, we know what's happened to the retinal nerve fiber layers. That's definitely thinned out. And then, just don't look at the pictures. Remember, the color is not all that important. Very important are these figures. So, if you look at it, 71, superior temporal, superior superonasal. Inferior part, inferotemporal, inferonasal. These are the areas, as every glaucoma surgeon knows, that you are going to have over here the thinning taking place first. So, and this now the picture corresponds to it. Whereas you look at this picture which I've put forward to you, not of the same patient, of a different one, and you find that it is all green. This green is the normative data which is of normal persons. And you find that the figures are 152, 144. Don't go for the colors. Go for the numbers. Oh my God, I better run. Very sorry, Dr. DT. I am unfortunately always doing that. Retinal nerve fiber layer, remember the thickness of a diameter of 3.45 millimeter around the optic disc. Now, this is what I was talking about, 3.4 millimeter diameter. You have to know where are the areas where the boundaries are, termination of the RP for the ONH border. This is the segmentation which I was talking about. Please have a look. If this segmentation top part has got cut off, it's going to extrapolate data. No use. Have a look, which I've already explained. Please do cover up each one of this. So each one is a clock hour. Then you have a look whether it is coming, your retinal thickness profile is coming within your normative data of normals. Had it come in the red, it is below normal, right? Then we come down to the next one. Look, as I said, look at this. The clock hours are very, very important. Suppose you've got early defects. A small clock hour defect may be missed if you take a huge sectoral large area. Both must be considered together. Dr. DT, they've already told me, they're showing me off.
Yeah,
okay,
I know.
now, so you have to look at all these areas. Please remember that in Indians, we are having, amongst males and females, it's different from the Caucasians. So this is now the right and left eyes, and you find that this asymmetry is very, very important where glaucoma is concerned. Now comes the macula. So in the macula, what are we doing? We are looking at the GCC. This is the thickness map. This is the deviation from the normal, and then comes the significance map. What about the significance? We find that this is highly significant. The patient has almost lost the entire thing. Don't forget to look at this RNFL, that is segmentation. And what about this? This is the only machine which gives us FLV, that is the focal loss volume. This is the most sensitive parameter which provides the difference between normal and glaucomata size, more sensitive than the GCC parameters. This is the GCC thickness map going serially, longitudinally over time and telling us, look at the amount of blue, and that's coming. That means there is progression. Also RNFL, you find that again, all the green has now become red. This is also telling us that there is progression. And similarly, the same thing just being shown another way. So you must assess your scan quality, look at the acquisition errors, and I want to come into some of the examples which are very, very important. So this was of a patient who was 51-year-old. This patient had, as you can see, he had an inferior almost hemifield defect in the right eye, left eye, nothing at all. And if you look at the OCT, you find that yes, the GC as well as the RNFL were showing similar defects. So there, the structure and the structure as well as the function are corresponding. Very good. Now comes an 81-year-old man. He's still within the normative data. Now he's got in the right eye, you can see that there is a small little, probably sedal scotoma, and this is a biarcuate scotoma. And therefore, when we look at it, but now you find that these OCTs are not corresponding with the fields. So remember, your criteria for diagnosing glaucoma is what? Fields or OCT? Fields, yes. So please let's forget that. Then comes a very important thing. Again, look at this CD ratio of 0.7, healthy NRR in this eye, but he has got a OCT defect out here. Whereas this one, look at this complete, and look at it. There's nothing left over here. And left eye, look at the optic nerve head, complete pallor. Please remember that our glaucoma can be confused with many neuro-ophthalmic conditions. So let's not forget that. You have to look at it. Now, another place, look at this is where you're having loss of data. This is mainly in patients who have got high myopia, or let's say they are aphakic, and you look at the amount of peripapillary oblique, the atrophic areas which we are seeing, and therefore this must be taken into consideration. This OCT is of no use to you. Then comes, next is the last patient where you have bilateral aphakia. Mind you, myopes not included in normative data, aphakics not included in normative data, as a result of which you cannot diagnose those patients because you don't have normative data. Don't forget to look at your normative data before you go ahead and diagnose a patient, right? And then comes AIOC2022, which already my friend has talked about. Remember, AIOC2022 can be used also for glaucoma. One very, very important thing, not just for diagnosis. You've done a PI. Is the PI really patent? Go ahead and check it out, because here you can see that, yes, there is a patent PI. You're very happy. Okay. Now, you must take all the correct measures in order to get a good scan. Now, this is the Heidelberg OCT. This is swept source OCT, and this gives us fantastic imaging. I will show you a video, which is my last slide. This helps the physician. A guy came to us. We couldn't make out head nor tail. The cornea was practically opaque, and as a result, what was behind it, we didn't know. Now, you just see how this AIOC2022, which is the Anterion by this Heidelberg, this helps you out. It's absolutely phenomenal. Now, that was that white opacity, and just imagine, I know that there is a gap between over there. So this video has been taken by none other than Hansel Anthony, beautifully done up, and this gave us an idea of how to deal with the patient. Thank you for your patient hearing.